For my video, I had vestibular case A, and based on her subjective interview and test and measures and outcome tests, these are the following results. She had negative spontaneous engaged evoked nystagmus, which means that this is not a central issue. Her smooth pursuit is normal. This also rules out a central issue. Saccades is also normal, also rules out a central issue. Her VOR is abnormal, which means that she has an issue with her eyes focusing on one subject while she's in a busy background or the world is moving around her. For her HIT, she had a positive test on the right side with corrective saccades. Her dynamic visual acuity was 4 lines. So 3 or more lines, the visual acuity relative to one static visual acuity is regarded as clinically significant and suggestive of a possible vestibular dysfunction. Hall-Pike was negative, which rules out BPPV. She also had a negative roll test, which also rules out BPPV. Her modified CAT-SIB test, on condition 2, she lasted for 30 seconds but had significant sway. And on condition 4, she only lasted 1 second, so she failed on that part. And this shows me that she has an issue with her vestibular system and is vision dependent. Her sharpened Romberg test, she lasted only 10 seconds with excessive sway with her eyes closed, but 30 seconds with her eyes open. Her FGA score was a 19 out of 30. This indicates that she's a fall risk. This can be used goal trying to improve her FGA by 6 points, as that is the MDC for the FGA. Her DHI was a 52%, which states that she has a moderate disability. Her ABC is 75%, so she's moderately confident. Her TUG is 18 seconds, which is high, because for vestibular patients, 11 seconds is the cutoff, so she is also a fall risk by the TUG classification. For her 10-meter walk test, she got 0.92 meters per second, so she is a community ambulator, but she is below the normal, which is 1.2 meters per second. So based off of all of those tests and measures, my main diagnosis for this patient is Meniere's disease, and my differential diagnosis is vestibular migraines. The reason I picked Meniere's disease as the main diagnosis is because the patient feels like her vision cannot keep up with her. Her vision is bouncing when she is walking or running. Her vertigo lasts for hours but is not consistent, and she has had only 4 episodes in the last 3 years. And she has tinnitus with sensorineural hearing loss in her right ear, but it has improved. For my differential diagnosis of vestibular migraine, the signs and symptoms there are dizziness, vertigo, headache, nausea and vomiting, sensitivity to light, sensitivity to sound, temporary tinnitus, loss of balance, neck pain, anxiety, fatigue, and disorientation. I chose Meniere's disease over vestibular migraines is because the patient is not currently experiencing migraines during her bouts of vertigo. She also does not have any nausea or vomiting. She's not sensitive to light or sound. The reason why I chose Meniere's is because the patient has had 2 or more spontaneous episodes of vertigo, with each of the episodes lasting at least 20 minutes to well over 12 hours. She's had audiometrically documented low to medium frequency sensorineural hearing loss in one ear. This occurs in the affected ear at least 1 instant prior, during, or after an episode of vertigo. She has fluctuating oral symptoms, which just means fullness here in her ears, difficulty hearing and tinnitus in that affected ear, and all the other vestibular diagnoses have been ruled out. So my treatment plan for this patient would be to refer their patient to a PCP or the audiologist to get a dehydration test to see if there is a reduction in the volume of endolymph or a decrease in the pressure. I also would refer them out as well to get a VEMP test done to assess vestibular function, and to test the saccule and inferior vestibular nerve, just to rule out permanent hearing loss. I would also do patient education on warning signs of a Meniere's attack. So these are balance disturbances, so feeling like somebody is going to come up and push you very aggressively, dizziness and lightheadedness, headache or increased ear pressure, hearing loss or tinnitus will increase, sound sensitivity will increase, and there will be a very vague feeling of uneasiness. I would also start the patient on the CAT diet, so limit caffeine, alcohol, and tobacco. I would also recommend that the patient starts to improve their sleep, because sleep just improves everybody's dysfunctions. And I would also refer to the PCP for medications like diuretics, just to see if that would help with the fluid overload in her ear. Okay, so for my first treatment for this patient is I'm going to have them do a Romberg exercise, since their sharpened Romberg score with their eyes closed did drop about 10 seconds from their eyes open. So what I'm gonna go ahead and have them do is go place their feet in a tandem stance, so one foot in front of the other, with their arms down by their side. And I want them to hold this for 30 seconds, twice a day. And then once this becomes really easy and they feel no provocation of symptoms and no sense of balance, no loss of balance, I would then progress them to eyes closed. This one I might decrease the time, but I would increase the amount of times they do it per day. Second exercise that I'm gonna have her do, since she does have provocation of symptoms when she's walking and running, I'm just gonna have her march in place. Have her do this, do 20 marches in place with her eyes open. And then as it becomes easier and her symptoms do decrease over time, I would increase the amount of steps she does in place to 30. And then I would have her do this marching test or marching exercise with her eyes closed. So do that for 20 times. Yeah. So for this third exercise here, since she does have dynamic visual acuity deficits, I would have her do V1, V2 exercises. Starting out with V1, I'm gonna go ahead and have you bring your thumb out in front of you. I'm gonna have you go ahead and shake your head, keeping your eyes locked on your thumb. At the beginning, I would want her to go, I would want her to shake her head as fast as she can without provoking symptoms. And then as she gets better, increasing the speed that she shakes her head. And then I would probably progress her to V2, which is now moving this in the opposite direction of what her head is going. This, again, probably would go down in speed at the beginning, but as she got more comfortable doing it and the symptoms weren't as bad, we would speed up the beats.